Rheumatic fever and rheumatic heart disease are important heart disorder. We are going to discuss about these topics. First, about rheumatic fever. It is acute post-streptococcal immune-mediated multi-system inflammatory disease, and it occurs a few weeks after an episode of Group A streptococcal pharyngitis. It has two major phases. First is acute rheumatic fever. It frequently manifests as acute rheumatic carditis. Then about chronic rheumatic heart disease. Here, deformed fibrotic valvular lesions are principal key feature of the chronic rheumatic heart disease. Then about age group. It is most common in children between 5 to 15 years. Then details about chronic rheumatic heart disease. The morphology of heart in chronic rheumatic heart disease are discussed below. Here, anti-streptococcal antibodies cross-react with the cardiac tissues and makes cardiac lesions. The cardiac lesions can be studied under two headings: acute rheumatic heart disease and chronic rheumatic heart disease. While discussing cardiac lesions, the ASHF body is very important. ASHF body is nothing but spheroidal or fusiform characteristic lesion in RHD patients. It has a size of 1 to 2 mm and it is present in perivascular interstitial regions of heart. Then about formation of ASHF bodies. It has three phases. The early exudative phase. Here, the perivascular factors of swollen eosinophilic collagen surrounded by lymphocytes, macrophage and plasma cell. Then in the second phase, it is called intermediate or granulomatous phase. It is a granulomatous lesion occurring phase with a central focus associated with the lymphocytes, macrophage and Anischko cells and plasma cells. Here we can see ASHF body and magnified view of Anischko cells. Before explaining this picture, we can explain Anischko cells in details. Anischko cells are clamp-activated macrophages with abundant cytoplasm. It has a round to ovoid nucleus and the chromatin are dispersed in central slender wavy ribbon, and it is also known as caterpillar cells because nuclei resemble caterpillar when cut longitudinally, and nuclei have all-eye appearance. Few Anischko cells may become multinucleated, in which case they are termed as Pathophysiology cells. So we can see longitudinal view showing caterpillar-like nucleus here, then cross view showing all-eye appearance of nucleus. So these are Anischko cells showing longitudinal view of caterpillar-like nucleus and cross-section view showing all-eye appearance. Then we can see macrophageal lymphocytes and fibrinoid degeneration, Pathophysiology cells, myocardial fibers, etc. And it is the magnified view showing the longitudinal and cross-section of Anischko cells resembling caterpillar and all-eye appearance. Then the third phase of ASHF body formation. It is called late or healed or final phase. Here ASHF body replaced by a nodule or scar tissue. Acute rheumatic fever is characterized by pancreatitis, that is, it involves endocarditis, myocarditis and pericarditis. First about endocarditis. It includes valvular endocarditis and mural endocarditis. We know that endocarditis is nothing but inflammation of the endocardium. First, we are discussing about valvular endocarditis. Here, the valve leaflets become inflamed and edematous. The left-sided valves are more prone to injury than right-sided valves. That is, the mitral and aortic valves are more prone to injury. Then the inflammatory damage leads to focal loss of endocardium and fibrin deposits along the line of closure of the leaflets. There are also small nodular or vertical lesions or vegetations called verrucae overlying the deposits. Then mural endocarditis. Inflammation of the mural endocardium is less prominent than valvular lesions. The most common is McCallum plaque. McCallum plaques, these are subendocardial lesions which appear as irregular wrinkled map-like thickening in the mural endocardium, and is usually seen in the posterior wall of the left atrium, just above posterior leaflets of mitral valve in ASHF, and it shows multiple ASHF bodies. Then about pericarditis. The fibrinous pericarditis and bread and butter pericarditis are important in this case. During acute RF, irregular deposits of fibrin are found on both visceral and parietal surface of pericardium, which causes fibrinous pericarditis. Then, the fibrinous pericarditis grossly resembles the shaggy surface of two slices of buttered bread that have been gently pulled apart. Hence, they are commonly called as bread and butter pericarditis. Then about myocarditis. The inflammation of the myocardium is known as myocarditis, and it is non-specific myocarditis with the lymphocytes, macrophages and ASHF bodies. In the figure, we can see fibrinous pericarditis, and in the figure we can see mitral stenosis with a verruca. Then about changes in affected valves. First about mitral valve. Here fusion of the commissure takes place, and the characteristic appearance is fish mouth opening. Then shortening, thickening and fusion of the chordate tendinate take place. In case of aortic valve, stenosis and insufficiency occurs. Tricuspid and pulmonary valves are rarely affected in this case. Then about extracardiac lesions. It includes migratory pericarditis. It is the usual presentation in acute rheumatic fever, and it is accompanied by fever. Then about subcutaneous nodules. These are spheroidal painless nodules attached to tendon or ligaments, and these are usually present on or located on the extensor aspect of wrist, elbow, ankles or knees. Then about erythema marginatum. These are skin lesions which are non-itchy reddish rashes. Then about Sydenham's chorea or Zient-White's dance. It is a neurological disorder with a involuntary, rapid, jerky, purposeless movements of trunk and extremities. Rheumatic fever also may involve other organs like lung, pleura and arteries. Then about etiology and pathogenesis of rheumatic heart disease. We know that it is a first streptococcal disease, and it developed after a latent period of 2 to 6 weeks after an episode of pharyngitis and tonsillitis by group A beta hemolytic streptococci, and it is most commonly occur in children. It is an immune-mediated disease which involve antibody-mediated reactions, that is type 2 hypersensitivity reactions, and T-cell mediated reaction, that is type 4 hypersensitivity reaction. In antibody-mediated reactions, some antibodies are produced against M proteins of streptococci, and it is seen to be cross-reactive with certain similar self-antigens in myocardial cells and glycoproteins of the valves. This may be the mechanism of pericarditis in acute rheumatic fever. Then, in case of T-cell mediated reactions, CD4 plus T cells are also activated by streptococcal antigens. These, along with antibodies, cross-react with self-proteins in heart. These reactions produce cytokines leading to activation of macrophages, which are seen in the lesion of rheumatic fever. Then complications of chronic RHD. It includes infective endocarditis, mural thrombi in atrial and ventricular chambers, then thromboembolism, then congestive heart failure, adhesive pericarditis and arrhythmias. Then about clinical features. Acute rheumatic fever is most commonly present with migrating polyarthritis and/or carditis, and the clinical findings of acute carditis include pericardial friction rubs, weak heart sounds, tachycardia, arrhythmias, and cardiac murmurs. Then about Jones' criteria for diagnosis of rheumatic fever. The major criteria include pancreatitis, migratory polyarthritis of the large joints, sudden Ham's chorea, erythema marginatum, subcutaneous nodules. And the minor criteria include fever, arthralgia, elevated blood levels of acute phase reactants, raised ESR and leukocytosis. Then about lab diagnosis. There is no specific serological test for rheumatic fever, and the pharyngeal culture for streptococci are negative by the time the illness begins. The antibodies to one or more streptococcal enzyme can be detected in the sera of most patients with rheumatic fever. These include antistreptolysin O, that is ASO, then DNase B, then anti-hyaluronidase. Then the acute phase reactants include raised ESR, C-reactive proteins.